Listen, clinical intuition is kind of a myth. Modern medical management, it's strictly dictated by population bias statistics. In this explainer, we're breaking down the exact mathematical framework that drives those high-yield diagnostic algorithms you absolutely need for a 280-plus score. Let's jump right in. Here's our blueprint for today. We'll hit the math of medicine, sensitivity versus specificity, avoiding clinical bias, screening algorithms, and then we'll wrap up with some intense, deep integration case studies. We're at Section 1, the math of medicine, establishing the evidence base. So before we even touch a patient, we've got to evaluate the data, right? Establishing evidence-based efficacy, whether we're talking about a novel antihypertensive or a new dietary intervention, relies entirely on the strict validity of the initial study design. Without a rock-solid foundation, medicine is basically just guesswork. This right here is the starting line for literally any study, the null hypothesis. Basically, we assume absolutely zero relationship between variables until rigorous data proves otherwise. Now, if we reject a correct null hypothesis, we've made a type 1 error, which is directly linked to our alpha or p-value. But if we fail to reject a false null hypothesis, that's a type 2 error or beta. And critically, a type 2 error is almost always a direct consequence of inadequate sample size. It's a complete lack of statistical power. Okay, watch out for this classic board exam trap. The fundamental equation is prevalence equals incidence multiplied by disease duration. Think about what this actually means clinically. Any intervention that improves survival in a chronic disease, like highly active antiretroviral therapy for HIV or those new modulators for cystic fibrosis, will paradoxically increase the disease prevalence without actually altering the incidence. The patients are living longer, so the total number of affected people in the population naturally grows. Moving on to Section 2, sensitivity versus specificity, diagnostic thresholds. Here's the golden rule for screening. Highly sensitive tests, the ones with a low false negative rate, are absolutely mandatory for fatal diseases where missing a diagnosis is literally catastrophic. Think of using an ELISA for initial HIV screening. It's a massive, wide net. But conversely, before you initiate any toxic, life-altering treatments, you must strictly transition to a highly specific confirmatory test with a low false positive rate. Things like an HIV Western blot or a PCR. You catch them with sensitivity, you confirm them with specificity. And this mathematical rule, it's frequently tested and completely non-negotiable. Predictive values are 100% dependent on disease prevalence. As the prevalence of a disease in your screen population goes up, the positive predictive value goes up, and the negative predictive value goes down. To put that into perspective, a positive result for an incredibly rare condition practically guarantees a false positive, unless your test specificity is just absolutely flawless. All right, Section 3, avoiding clinical bias and identifying those sneaky vignette traps. These right here are the usual suspects: lead time, recall, observer bias, and the Hawthorne effect. Researchers, and frankly, you as a test taker, must actively identify these to avoid catastrophic misinterpretations of clinical data. Let's map these to precise clinical scenarios. Lead time bias is essentially an artifact of early detection. It artificially inflates survival time on paper, but it doesn't actually alter the terminal prognosis. Then you have recall bias, which classically plagues retrospective case control studies. That's where patients with a disease systematically overreport past exposures compared to healthy controls. And the Hawthorne effect? That's when patients alter their baseline behavior simply because they know they're being observed in a trial. Keep these in your back pocket. Section 4, screening algorithms, taking the theory and turning it into clinical practice guidelines. Listen, these management steps are absolute and non-negotiable. For colorectal cancer, average-risk patients begin colonoscopies at age 50. But if they have a first-degree relative with colon cancer, that baseline strictly shifts to age 40, or 10 years prior to the relative's diagnosis. And for familial adenomatous polyposis, or FAP, the math guarantees a near 100% risk of colon cancer by age 40, which makes aggressive early intervention and prophylactic colectomy the strict clinical mandate. No exceptions. Pay very close attention to this algorithm. The absolute first step in management for a newly discovered solitary pulmonary nodule: review previous CT scans to establish stability. Clinical vignettes will aggressively try to trap you into selecting an immediate biopsy or surgical resection. Don't fall for it. You must establish baseline risk first. Now, if prior imaging is completely unavailable and the patient has high-risk features, like an extensive smoking history, advanced age, or a spiculated mass, then, and only then, do you strictly mandate surgical resection. Finally, Section 5. Deep Integration Case Studies. This is where we execute our clinical logic. Okay, look at this scenario. When a young man presents with a history of brain cancer and a newly discovered pancreatic mass, statistical probability points straight to von Hippel-Lindau disease. But to hit that elite caliber of understanding, you've got to recognize the exact underlying mechanism. This pathology is driven by a mutation on chromosome 3p, leading to constitutive HIF expression. This single mechanistic detail perfectly explains the statistical clustering of highly vascular tumors we see in these patients, like hemangioblastomas, clear cell renal carcinomas, and pheochromocytomas. And right here, we're looking at Kemmel-Steele-Wilson nodules, the absolute pathognomonic hallmark of diabetic nephropathy. But the high-yield trap is recognizing the initial pathophysiologic mechanism, efferent arterial hyalinosis causing hyperfiltration. It's this hyperfiltration that is the direct precursor to the nodules you see here. It reliably alters the glomerular basement membrane long before those kidneys ever progress to end-stage failure. The big takeaway here, biostatistics strictly dictate clinical reality. Every clinical hunch is really just a rapid calculation of statistical probability. Now, let's execute a final master case that tests your ability to deeply integrate everything, from pharmacology to sudden hemodynamic collapse. Let's conclude with our master case testing strict integration. Here is your blueprint. A 28-year-old female presents to the ER with sudden onset, severe right upper quadrant pain, lightheadedness, and hemodynamic collapse. Blood pressure is 85/50, heart rate 120. She has a 10-year history of oral contraceptive pills. Now, the diagnostic trap here is embedding a low-grade fever and extreme tenderness to aggressively tempt you into diagnosing severe acute cholecystitis or a ruptured ectopic pregnancy. But a bedside fast exam reveals a solid hepatic mass and free fluid in Morrison's pouch. You have to bypass those infectious distractors. She's suffering from a ruptured hepatic adenoma, the estrogen-driven threat. These are highly vascular tumors completely lacking normal biliary drainage, carrying a catastrophic risk of spontaneous rupture. If this was unruptured, the absolute first step is stopping OCPs. If it's strictly over 5 centimeters or symptomatic, surgical resection is absolutely mandated. On test day, your option matrix will contain exactly 5 distinct choices. You must forcefully select the underlying mechanism, estrogen-induced hepatocellular proliferation. You must reject focal nodular hyperplasia, the hyperplastic scar. FNH is driven by an anomalous artery, shows a central stellate scar, carries absolutely zero risk of rupture, and strictly requires simple observation. And you must absolutely reject the vascular malformation hepatic hemangioma. That's a tangle of cavernous endothelium-lined spaces showing peripheral to central enhancement. If you see that, percutaneous biopsy is strictly contraindicated due to fatal hemorrhage risk. Master these precise mechanisms, avoid the traps, and I'll see you in the next explainer.